holes through the remaining cartilage into the subchondral bone. This was known as pretty microdrilling. And it was really Stedman and colleagues out at Vail who introduced the true microfracture. So they removed the remaining cartilage base and directed drilling or oiling or picking into the subchondral bone. So they'd make multiple holes, 1 to 2 millimeters, 3 to 5 mm apart. And the whole principle was that as you burrow these holes into the subchondral bone, you're really stimulating that subchondral marrow. So you're allowing an escape vent for these cells to come up to the surface, form a fibrin platelet clot, and hence transform into fibrocartilage. So the pluripotent bone marrow stem cells will come up. So you can see in the here control versus the treated group. So it does lead to cartilage formation, and that's been theoretically proved and by clinically proved in multiple studies and histological analysis. So the hematoma comes up, forms a fibrin platelet clot, and you get healing by what's known as Dr. Kronal was saying, it's fibrocartilage. It's a repair cartilage, which is never as good as true cartilage. So the fibrochondrocytes, which are derivatives of those pluripotent stem cells, they deposit this type 1 collagen-rich fibrocartilage. And this is biomechanically inferior, and it's been proven by multiple studies, it's biomechanically inferior to the rich hyaline type 2 cartilage. It has a less load to failure, there's a less yield point for the repair cartilage. And that's why the results of this have been traditionally good in the short term, but they've been very disappointing in the long term. So what is 21st century enhanced microfracture? So what are we doing different now as compared to what we were doing different about 10, 15 years ago? So now we're combining our microfracture techniques with the introduction of a thin layered blood absorbing matrix scaffold, which basically fills the defect. And this can be collagen type 1, type 3, or something like chitosan gel. Uh, Even though any additional benefit of it hasn't been clinically supported. And in the initial studies, there was a relatively high biocompatibility failure of these implanted materials because they used to trigger an inflammatory response. So now what we're doing is trying to circumvent this problem and trying collagenous membranes. So they have good biocompatibility. You don't get that strong inflammatory response. And so there's things like autologous matrix-induced chondrogenesis or AMIC, for which RCTs are underway. Also under investigation is combining microfracture with stem cells or growth factor therapies. And this is basically where the future for microfracture is heading. So we've moved across that era from in 1959 to 21st century enhanced microfracture techniques. Oops. Yep. So the indications and contraindications for microfracture. So full thickness cartilage defects, unstable overlying subchondral bone, or a partial thickness. So age is a big determinant. So we see the best results again with the younger cohort, and it's theorized that they have more active stem cells to be able to transform into fibrochondrocytes. The size of the lesion also plays a big role. The smaller the lesion, the better the outcomes because it's able to contain that fibrin platelet clot better within the defect. But really what we know now is that the height of the cartilage surrounding the lesion has paramount importance. The bigger the wall around the lesion, the better you'll be able to contain the fibrin platelet clot, the better transformation that will happen to fibrocartilage, and hence the better results. So the contraindications are poor rehabbers, those with systemic arthritis or what we know as hostile knees, and those with malaligned knees. So if you're doing microfracture in a case of a malaligned knee without a corrective procedure, you're probably doing something wrong. So post-operatively, rehab is critical and paramount. So this is my rehab protocol, and this is the one that I've been following, and it works quite well. So we do cryotherapy day 1 through to day 5, CPM. For the patella lesions, we usually limit it to about 50 degrees. For the femur and tibial lesions, up to 70 degrees. We do crutch-assisted touch weight bearing, 2 weeks for patella lesions and 6 to 8 weeks for femur or tibial lesions. Patients are put into knee immobilizer, 2 weeks again for the patellas while they're touch weight bearing, and 6 to 8 weeks for the femur tibia ones. They're full weight bearing at about 2 weeks post patella and about 6 to 8 weeks post femur tibia. Sports, we usually tell our patients that 4 months after a patella and 6 months after a femur tibia. And a functional knee brace, we put them on for the femur tibial lesions from post-op second month to the post-op fourth month. So what does the literature say? I'll just quickly run through this. So most of the work that's been done in this has been published in knee. So surgical treatment of cartilage defects. So this is a systematic review of randomized controlled trials, which was done by a very good friend of mine, Brian Devitt. So they looked at 10 trials and they basically found out that, which lesions are amenable to ACI-MACI and which ones work better with microfracture. microfracture. So if you see that out of the 10 studies, there's only two studies that had better results with OAT than with microfracture. So there's a microfracture for cartilage repair. This is another systematic review. It's more up to date. It came out in 2019. And it showed that microfracture provides good function and pain relief in the midterm as well. So we're moving beyond the area of early term results. And this is the latest stuff that we've been doing. So enhanced microfracture with acellular scaffolds. So it does work well, but there's a long way to go. So there's no really recommendation for this yet in any of the societies, but this is sort of, the thing that we're looking at when we talk about the future of dealing with microfracture and what 21st century microfracture really involves. Great. Thank you. Any questions from the audience?
Manik, what was indeed a very nice presentation.
So have you started doing any hybrid procedure vis-a-vis microfracture in India, back in
Yeah,
Mohali?
so what I do routinely, sir, is I do my microfracture and I combine it with tissue. So if there's a cartilage flap, so I'm more of a shoulder surgeon than a knee surgeon, to be honest.
Okay,
But in the shoulder cases where we have vertical sort of cartilage flaps, what we do is the same thing that we do with hip scopes. So we
okay.
put a little bit of microfracture behind that cartilage defect, and then we'll use tissue and just glue that flap together. So I found that the outcomes are better with that than if you do just microfracture itself. So when we look at our Constant and UCLA scores, they were trending better for the
Okay.
TCL group than for the non-TCL group.
And
So if
about, okay,
if I share my experience with microfracture, it is probably one of the most done surgeries in my hand. Reason being, if we coincidentally find a chondral lesion specifically in ACL deficient knee, they're also more of a not acute but subacute to chronic cases. Then along with the reconstruction, I usually add microfracture, and they all do extremely well. I don't know the reason being
No
uh,
one knows the
just
reason because
reconstructing
biologically it
ACL
doesn't
and
make
then
sense.
probably elevating the etiology of chondral defect or along with that microfracture. But they all do extremely well. In isolated chondral lesions, my experience of doing microfracture has not been so well so far. But as you said rightly, in our country, sometimes it's just a sort of escape. Yeah.
now the issue is like in ACLR, you find them as a, sometimes unwarranted defects, which you don't even anticipate pre-surgically most of the time. And they are usually smaller defects. And as you said, they are repeated micro or macro injuries and pivoting. So you have a pattern of loss mainly on the medial
Medial
side
side,
along with
yeah.
the medial meniscus flaps.
True.
So there, I think a kind of delamination or smaller lesions, which are less than a centimeter or sometimes even 1.5, that is, I think, fair enough in young patients. And there, when you are not even anticipating that you are not maybe ready with OATS or maybe you are not prepared for ACI in a higher class patients, you can always wait and watch and tell patient that this may be dealt in if at all we need to in a future date. But the primary issue is the instability. So maybe you repair meniscus or excise, but mainly stabilize the joint. So I think that's a good procedure for most of the patients in trauma because you don't have large traumatic OCDs or OCN in trauma. Like you have major osteochondral defect with ACL. I think most of the people don't have that. It's an isolated one which you showed on the LFC. So I think osteochondral pathologies and traumatic lesions, they have some principally common base, but I think pathophysiology is different.
The second scenario where I have been using this microfracture as my weapon is the subpatellar the patellar chondral defects, because I'm not very comfortable doing OATS and ACIs in that region, though people are doing it very efficiently. With my hands, I'm not very comfortable. So there is a second
See,
Feel
scenario in which
outcomes
I
in the
do use it
patella,
often.
Dr. Krunal?
Yes.
patella, I think it's a very good indication in our country. And when you have a very large defect, especially in the dislocated or dislocating patellofemoral joint, ACI, we have done couple of cases, but it's the challenge to get them back to the sports because the protocol you cannot, side step or your short chat the protocol or rehab. and you cannot get them to
Yes,
very
Manoj bhai,
quickly.
So, what's
please.
your opinion for a microfracture in the older sort of population? So, between that 40, 50-ish age group, you
My
got
I,
any?
I in my initial days I was quite I would not say very aggressive, but I was quite optimistic about those cases and had repented a lot doing microfractures above 40 or 45 rather cases. So probably
See,
these are the cases in
again,
which any arthroscopic or any salvaging procedure, though been done well, they don't give good results unless and until it has been done with alignment correction. If I do it with HTO,
see,
probably it is one of the best.
again, the main important thing is pathology. If it's an early gonarthrosis with chondral defect and the varus grade 1 or whatever, that's again what you're saying is right. But if it's a traumatic one, even in a 55, we did our, the eldest patient, like 63, I have done ACI. She had an absolutely pristine knee.
Right.
And even at 63, we have done ACI in MFC. I was very skeptical because she was 63.
Mhm.
But it was a traumatic injury and she never had any knee pain. We got the MRI done, even 3T MRI we did, alignment, everything. But otherwise, beyond 50, you won't even think of doing any of things. So what you
I
are
think
saying,
Manoj bhai has to mention something. Yes, Manoj
yeah,
bhai, please.
So the question was, microfracture is a very controversial topic as such, and though practically we like microfracture because it's easy, practical. We can introduce the same procedure in our routine ACLs and other procedures, but the long-term follow-up is important, which we don't tend to do regularly with the microfracture.
yeah.
And we had a long discussion with Dr. Deepak Goyal also that a lot of issues with microfracture in the longer term, and he has explained very well why we get those issues. So, like getting those the bone islands and osteophytes along with the cartilage causing the pain. So, one of the discussion was the number of holes to be made for the microfracture. So I would be asking Dr. Arora, how many holes does he prefer to make at what distance, and what is the density of the microfracture holes he makes?
So, sir, I usually just follow what Stedman said. So, 1 to 2 millimeters, 3 to 5 mm apart, and I try to cover the whole defect, but I make sure that the holes aren't overlapping or crossing or touching, because what you're doing if you're crossing the holes, you're basically creating a subarticular fracture.
Yeah.
So, so that's why I make sure that there's no stress rises. They're sufficiently spaced apart. I turn off the pump or I turn off the fluid, and I make sure that there's some good bleeding that's happening into the base. So that way, I'm confident that once I let go of this knee or I let go of this shoulder, then it's going to feel nicely with a good vibrant rich platelet clot. And but as you said, sir, the long-term outcomes is really the bad thing with microfracture. So we all do it for that short-term happiness, but it's long-term pain.
The shoulder, it will be forgiving because it's a non-loading joint.
Right.
But in
And,
knees, we have to be very, very specific.
and how do you determine the depth of the hole in the microfractures when you do that?
So when I'm using the oil or the micropick already has a set on it, so you can't go beyond that set. So the micropick has its own depth built into it, so it just hits and blocks it. But
For
with the
somebody
oil,
who
I
doesn't
try.
have, yeah,
Yeah,
because there are a lot of surgeons would prefer a K wire over a pick doing microfractures.
right.
So what
I
would
think
be
that
your
if you just break through that first 4 to 5 millimeters of bone, you're pretty much into that nice, rich, that stem cell niche. So that's what all the histological studies now are focused on as well, the stem cell niches that exist under that subarticular space. So if you're creating a vascular channel or pocket into them, then the bone fragments will come up, they'll align with them, and they'll create a nice, rich, fibrin clot with these small, bone marrow fragments in there. So I think that sets really nicely.
and do you use a combination with the hyaluronic acid in any cases?
I did, but I never really found that it had any clinical benefit, to be honest. Like I used it, but the cases I felt that, they weren't doing that much different to just doing a simple microfracture. What's your take on it? Have you had a different experience, sir?
No, not only few cases, but I haven't studied them for long term. That's why it's a discussion whether we should incorporate uh, This
But
hyaluronic
hyaluronic
acid.
acid has its own half-life anyway, so as time goes by, it would anyways degrade.
Any
Yeah,
inputs
it's
from Dhruvil, Prathamesh, or Sanjay Bhai regarding any of these two cases, and any inputs you want to put regarding these two cases?
I
all
think for young patients, I prefer ACI, though it is a two-stage. The next thing that I'm going to present is a one-stage cartilage repair. So that is what I have started doing now for the young cases. As Nilesh sir already mentioned, that the long-term result with microfracture is something which is a worrisome thing for us. The reparative tissue that actually generates on the cartilage defect with in long time is the thing that we really want. It should be as normal as the native cartilage that the patient has. So the main focus of all the techniques that we are trying to do now is to have a reparative tissue, which is matching the normal hyaline cartilage of the individual. So isolated microfracture in young age, I don't prefer. Maybe in old age with malalignment. So knee restoration surgery is the most common in my practice these days.
So,
Malalignment is probably the only time I wouldn't do microfracture.
Dr. Arora, in your case, the MRI was showing that subchondral fracture and
Right.
some fragmentation, probably a soft base. If you had used oats in that case, was there a chance that it could have dipped in?
Yeah, so that was the reasoning. So when we'd sat down and we'd gone through it, one of the big reasoning that we had for avoiding oats was that we felt that once we sink in the graft, it may just sink too far into the bone because that whole shell behind it was so weak. So we felt that if we hammer it and put it in, it may just sink into the depth and actually be recessed below the surface. Once it's below the surface, it's equivalent to doing nothing.
So probably I think that was the philosophy behind using microfracture in that case.
Yes,
see, the whole ball game is again going back to the subchondral bone. So if you don't assess the subchondral bone, any of these procedures are not going to give you what you wish.
No, no, Nilesh, the issue here was it was a difficult decision.
Yeah, I saw that MRI, and the subchondral bone beyond the area where he did the microfracture was maybe dicey.
Yeah,
So
so as
they,
Dhruvil said, we wanted a normal cartilage there,
yeah,
but the subchondral bone was not there to support our.
yeah. This was just an escape treatment what they gave to the patient. He demanded, I need this. I want to get back to the field. So maybe a good case to present, but I think if you discuss it on the merits, not the right thing to do. So we
So
can go with the next.
Yep. So I'll just introduce Dr. Dramil. He's a excellent knee surgeon at Vadodara, and I'd like to invite him for the next talk, please. Thank you.
all right, thank you, Manit. Uh, Nilesh bhai, can you see my screen?
Yes, yes.
Okay. So because this is a case-based discussion, I'm going to present a case of an all autologous cartilage repair, which we perform these days in one stage for our patients with cartilage defect. This is a 21-year-old male with history of allergy to pain medications. He had a right knee twist injury due to a major fall from stairs on the 8th of November 2019. He presents to me 3 weeks later with a knee which has pain scale 7 out of 10 and swelling. His main problem is he's unable to completely extend the knee. He has a fixed flexion deformity of around 30 degrees. The knee is otherwise stable, and he has this problem in walking because he's not able to extend the knee completely. So that is his gait with a flexion knee. That is his standing X-ray of the right knee, which is grossly unremarkable except for the effusion that we can see on the lateral view. His scanogram right side doesn't show any major malalignment, though the normal left side does show varus. These are his MRI images 3 weeks post-injury, and we can see that there is a full thickness cartilage defect in the medial femoral condyle. The coronal images confirm our diagnosis of a full thickness cartilage injury near the attachment of the PCL on the medial femoral condyle. That's the notch view for the knee, which shows that the cartilage is lying as a loose piece in the intercondylar notch. It has flipped almost 180 degrees from its site of origin. And this is what we get from the MRI, the dimensions of the cartilage loose body that is there in the notch. 21 millimeters in AP dimension, 23 in transverse, and 4 millimeters thick, which gives us a preoperative cartilage defect Amadeus score. Amadeus, by Amadeus we mean the area of the defect, the depth, and the underlying surface of the defect, which Nilesh Bhai has rightly mentioned. We need to see the subchondral bone. It gives us an Amadeus preoperative score of 50, which makes it a grade 3 lesion. So I wanted to tell you this because for all grade 3, grade 4 lesions on preoperative diagnosis on my MRI, I usually prefer a cell-based therapy. These are the arthroscopic images of the patient where you can see that there is this flipped loose body in the intercondylar notch. So I removed the loose body from the knee because I did not think it would serve a purpose if you fix it back to the native site. And this is what we are left with on the medial femoral condyle, this big defect. Therefore, of course, I never wanted to repair that loose body because it lost entire attachment from the native bone. Autographed oats, I think I saw presentation of Kunal Bhai, and yes, it was a big defect for me to think about doing an oats because I am reluctant to get more than 3 osteochondral cylinders from the non-weight bearing portion of the trochlea. The center where I work in, I don't have easy access to allograft, so allograft oats was not an option. 2-stage ACI, yes, it was possible, but with prior discussion with the patient, we both agreed for a 1-stage all autologous cartilage repair. And this is the technique which I am going to present. This is the step 1 of the procedure where you harvest autologous cartilage from the non-weight bearing zone, the medial aspect and the lateral aspect of the trochlea, as well as the notch. The important thing here is to have your shaver on the oscillating mode and to have a bone cutter shaver blade, which is usually not more than 4 millimeters in size. Another important aspect of this technique is to connect your shaver with a graft net device. This is marketed by Arthrex, and this graft net device has a receptacle which collects your cartilage from the knee joint. And when you open this graft net, and on the kidney basin on the back table, you can get this kind of cartilage paste. In this case, because it was a big defect, we thought of mincing the original cartilage loose body that we removed with the help of an 11 number blade into small cartilage pieces like this. And then this entire cartilage was hydrated with 1 cc of platelet rich plasma, and it was filled into a syringe, 5 cc's or 10 cc's as per your preference, attached to 18 gauge or a 16 gauge needle. This was injected under direct vision into the knee joint like this. The left side shows the preparation of the cartilage defect. The middle image shows injection of the cartilage paste. And the third image is when you try to spread the entire cartilage. Now, the important aspect is, how do you want to fix this piece onto? And that is where we use natural fibrin glue from the patient's whole blood. We prepare autologous thrombin serum with a thrombinator system that you can see on the left side of the image. And this autologous thrombin serum is filled into a dual syringe that we can see on the right. It's injected in the joint with platelet-rich plasma and forms a fibrin glue in 15 to 20 seconds. So that is how you inject the natural thrombin serum with the PRP into the knee joint onto the defect. And on the right side is the final arthroscopic image of the procedure that we do. So I'm going to present a short video technique of how we do it. The first thing is obviously preparation of the cartilage defect. And as Manit rightly pointed out, we use a chondral pick. It creates less heat generation. And there is a depth stop. So you cannot penetrate more than 3 or 4 millimeters. You want to have a good stable bone marrow cells at the base of the cartilage. The next step is to have an accessory high medial portal where I park my laboratory spatula or a thin osteotope into the medial gutter, after which you want to remove all the blood and the water from the knee joint because the next steps are going to be under dry arthroscopy. we have to be gentle when we do this. And then for the cartilage defect, we use sterile cotton buds to dry out the base of the cartilage defect. After which, with the help of a 16 gauge needle, we inject the cartilage paste, which is hydrated with platelet-rich plasma, onto the defect. And we know, as Dr. Nilesh mentioned, that to get the right trajectory into the knee joint while doing an arthroscopic procedure is very difficult. And that is why the role of this laboratory spatula or a thin osteotome is important here, where you want to use it to spread the entire paste nicely, slowly, and maybe uniformly over the cartilage defect. We as trauma surgeons sometimes find it difficult to have the patience for this, but yes, I think this is the step which requires a lot of patience. And once you are sure that you have been able to spread the cartilage paste properly over the defect, that is when you want to inject the fibrin glue to stabilize the paste onto the defect. So that is the activated thrombin serum with the platelet-rich plasma, which usually sets in 20 seconds after you inject it into the knee joint. And again, you can use the spatula to spread the paste of cartilage with the glue onto the defect. The rehab, well, Manit has very nicely mentioned what rehab he follows, and that is the same for all the cartilage procedures that we do in our clinic. Non-weight bearing for 6 weeks is something which is very important. And we start CPM mobilization from the second or the third post-operative day based on the comfort of the patient. This, of course, is his 6 months follow-up. These patients do better even in the early post-op phase. Almost 3 months, they have no pain because of the surgery. And he has good quad stands, of course, with half squats and full squats that he does in his gym that we allow usually after 3 months. The only thing that we restrict is sports for most of these patients. Impact sports is something that I'm not confident for these patients to pursue early. So we wait for maybe 15 to 16 months before they go back to sports. His knee score 6 months post-op was 1, which was pre-operative was 7, and the post-op score was 1. That's his post-operative MRI. I think clinically most of our patients do good, but I think it is very important to see on post-operative MRIs the quality of the repair tissue that is there at the cartilage defect site for all the effort that we put in. And that you can see on the MRI, the coronal images, that it has good cartilage healing at the defect. There is some subchondral bony edema that we can see. And this sagittal post-operative MRI image also shows good intake, good uptake of the cartilage cells that we put over there. There is some surface irregularity, but that is less than 50% of the entire cartilage defect. This post-op radiology, again, is something which is important with these patients. And we our 2 score for these patients. For this patient, it was more than 70, which is comparable to the other cell-based therapies that we do. In conclusion, what I want to convey through this case is that we can do a one-stage procedure when it comes to cell-based therapy because we are using autologous cartilage cells from the patient's same knee. I would prefer this procedure in younger patients only because they have a good regenerative potential for the reparative cartilage tissue over the defect. Short-term and medium-term results for all the autologous minced cartilage doing when of course this is economical as compared to the 2-stage ACI that we do or the allograft oats that most of us don't do in India. And again, you can always do it as an open procedure if needed. So there is no compulsion to do it arthroscopic. Thank you.
It's a wonderful presentation. Good. Thank you. Thank you very much. In fact, indeed a good procedure. I'm sure there will be questions. So I would like to ask you one first question. Any role of using CO2 inflator in when you do this cartilage in CO2 inflator, which endoscopic people use? Because I've been in UK, they used to do this quite a lot. This dry procedures, cartilage procedures, and fibrin glue, and all those. And it helps a lot to inflate the joint and make it more comfortable because all these endoscopic endoscopic OT setups, they do have this thing. You just need to detach the water in the saline inflow and attach this CO2 inflator. Just asking whether there is an experience.
It's a good suggestion for a dry scope, which they
Yes.
use it for the laparoscopy. So for lap, they use the CO2 insufflator. So particularly when you are implanting, if you want to have a clearer or little better hemostasis, I think a CO2 insufflator or that generator can be utilized. But we orthopedic guys, I think we are very skeptical about using which you don't use it every day. So for
Yes.
ankle implantation of ACI, we cut off the fluid and you will have a little bit of oozing here and there. So you could insert your shaver with the suction on and try to dry it up, or maybe as you showed that you use that cotton bud to take away the blood. So you try to be, time conscious and how fast you can implant it. And since this lesion was fairly in the frontal plane, the arthroscopic procedure was absolutely called for. But if it was a deeper lesion underneath on the central and posterior area, probably arthroscopy would have been a challenge, especially in a stable joint.
Manoj,
Yes.
So, when we are using a mosselized cartilage, which is similar to the technique which is used by Dr. Kevin Stone since many, many years, we also had a big piece of acutely fractured chondral piece. Wouldn't it be better to fix that piece back rather than using a mosselized cartilage in this? Because most of the cartilage was used was from the piece.
So
Only
I have
small part is coming from the.
I had the same question.
I have an experience of using headless cannulated teeth screws for fixing the cartilage defect. And this was a young patient with a 3-week-old injury. My only concern was that this was a flipped piece of cartilage that was lying unstable inside the knee joint since 3 weeks. I was not sure about the viability of that cartilage piece. It was just 4 millimeters thick. And when you try to fix a 4 millimeter thick cartilage back to the bone, how much are you going to sink in the headless screw is a big issue for us. Sometimes you end up, making the screws proud just so that you have a better stability of the fixation. And I was worried that if the superficial layer of the cartilage goes away, then those screws are, inside the joint and that might damage the cartilage. So just because it was a 4 millimeter thick cartilage loose body, I was not sure of fixing it. I have had an experience with a patient where I have fixed him with screws and then I have to remove it at 2 months just because the superficial layer just got worn out with his knee flexion and extension movement. That was the main
Yeah,
reason why I used this
The,
technique.
the reason for this is that if you see the physiology of cartilage, as we know that it's supposed to have a very weak healing potential. The reason is because there is a progressive death of the cells. When one cartilage is injured, there is a progressive death of surrounding cells. So whenever
Yes.
you fossilize the cartilage, probably you are going to induce a lot of damage to the viable cartilage.
Yes.
So, and we also cause irregularity in the surface, which was a smooth, nice cartilage. Third thing, whenever you see a cartilage at 3 weeks' time, a 4 millimeter thick cartilage, it is quite rubbery and easily suturable. So you don't need to use screws until unless you have a bone, sliver of bone there. So
Okay.
looking to
Even
all these
even
things,
Arthrex
a
and
lot of
some of the
people are
other
doing
companies,
suturing of the cartilage piece there, and you
even
have a
Arthrex and some
natural
other companies have this radiolucent biodegradable K wires also, which I have used so many of times with a fiber wire or something to tie up the piece specifically on the undersurface of patella though, but even it
see,
can be used.
yeah, and
I
so the
think, yeah, go ahead,
so you,
Manoj, go ahead.
yeah, technically you've done an excellent job. I'll say that's commendable. Only thing is our discussion is for the physiology.
Yes.
See, it actually still, I'm not convinced with what they're promoting. It's a single shot surgery, but probably what you're getting the result is because of the microfracture and the PRP and all the biofactors which are helping the lesion too. And particularly in this case, it was a partially non-weight bearing lesion into the notch, medial wall of the MFC, and partly going into the medial femoral condyle. So probably this will be fine because that was the right case for this kind of new procedures which we want to use and try to see whether it works. But physiologically, what
So
Manoj is
if it
saying,
if it was on a patella or a trochlea, I wouldn't do this. I would go for a two-stage ACI, because, or if it was on a bigger lesion on a weight-bearing, more
Yeah,
weight bearings on the femur, I would go for a.
obvious, obviously. So this
Yes, yes,
particular selection was good, I think, and probably you will not face any music, or the patient won't face any music, because this is
yes.
going to do well. But see, again, a morselized cartilage implanted in the same stage, whether it will become a hyaline type 1 cartilage, I'm still not convinced. We'll see and wait for the further studies.
I think we are going to do a rescopy on him after 1 year and see how it
Yeah.
goes. Maybe.
Yeah,
So
yeah.
I would suggest if you do a rescoping, you should take a small piece for biopsy and then we should
Yeah,
check.
Okay.
that would be nice.
So
We move on to the
if there are no
next.
questions, then probably we move on to the next talk by Manoj Bhai regarding the patellar chondral defect, simplicity for difficult situation. Dr. Manoj, please. Sir.
So can you see my screen, please?
Yes.
Yeah. So first of all, I would like to thank Arthrex and Ortho TV for giving me this opportunity to present here. They have given me a topic which is one of the most difficult subjects and asked me to simplify it. Yeah, it's a situation. It's like it's like a cool situation. So let me try my best. So first thing, what scared me was talking about this bone, patella, and this small little patella, which everybody knows is a sesamoid, a large sesamoid bone lying in the extensor mechanism of the leg. It has a very complex biomechanics for which we can talk probably for days together. But we know that it controls our quadricep mechanism. It helps in the open chain function and also in the closed chain function. It has a property of shock absorption when you are doing the squatting, running, jumping, all those activities. It has a very important function of stabilization. The important word is stable because if you see the figure on the right side, that's the angle of the direction of pull on the patella, and we that patella needs to stabilize in all movements, and there's a lot of force being applied to the patella, which is almost 7 times the body weight, and a very great shear force, which is much greater than the tibiofemoral joint shear force, and still patella works for years together beautifully. So let us try to understand with a case. This first case is a very dear friend, orthopedic surgeon, and this young gentleman. He likes to do a lot of sports because he wants to lose his weight, but he's very strong, and he did his regular gym exercises. So one fine day, he has this acute pain in his knee with a sudden popping sound, a lot of swelling in the knee, and he was not able to walk. So he got worried, and he got his X-ray done. His X-ray showed a flake of bones. He got worried. The second thing what he did was he went for a CT and MRI. So this CT showed a flake of bone lying there. So as a trauma surgeon would immediately think, okay, let's find out where it's coming from. So he got his MRI done. And that's the MRI picture. And you can see very nicely there is a loss of cartilage on the patella, on the middle facet. That piece lying in the lateral gutter coming from that defect of the patella, lot of blood and effusion there, a tear in the middle ligament of the patella, and probably a trochlear dysplasia kind of flattening seen on the trochlea. So now he comes to me with this picture, and I have this multiple options in my mind. So I put this question to you: what would be your choice? The panel here, whether we put a simple brace in extension and do nothing, we do an arthroscopic removal of these loose fragments, or some we do a removal of loose fragments and do some ligament reconstruction, or we fix the fragment back and do a ligament reconstruction, or we do a fixation fragment and MDF just repair. So a lot of options. So what would be your choice? Kunal bhai? Dr. Kunal?
Yeah, I would fix the fragment. I would fix the fragment.
And would you touch the MPFL or do nothing for that?
See, I'm not very good in repairing these ligaments in first say, so I would do a reconstruction of the MPFL, and that I've done both the things in single stage in some of the cases, because I was not very sure whether this is going to recur, or I was not very sure whether I would be doing a good repair. So in that case scenario, I have done both the things together in some of the cases, but I cannot justify that. So I was quite reluctant saying reconstruction part.
So with his age at 42, still would fix the fragment and reconstruct the MPFL, right? Any other, Dr. Manish, Dr. Nilesh Bhai?
Basically, the type of, it's an avulsion from the patellar side, usually that defect on the medial side. So if you have a good enough osteochondral piece, probably you can repair it along with the primary repair and refixation with whatever suture material you think you are comfortable with. But if you have to lose, if you have to remove it, probably I would not go in with an MPFL reconstruction on the first set. I will let that as a second stage as a formal MPFL reconstruction, because MPFL per se is a very small, ill-defined structure which cannot be primarily repaired properly. But if you are able to do the fixation of fragment with the MPFL, then I think that's the best case scenario.
And Dr. Prathamesh?
So I'll do a fixation of fragment with MPFL repair.
Yeah, that's the way if it's an acute one-off big piece. But MPFL reconstruction on day one of the primary event, I think it's a little too much.
Any other? Okay. So this I had discussed before with another group, and one of the consensus was that this is a medial facet cartilage, so we can remove and throw it off. And it's not going to hamper much with the function at 42. And when you are doing, you can also repair the MPFL in the same setting. So this is another way of doing it. Now, so what I did, so I did an arthroscopy for this patient, for him. And let me show you. This is a very, very old video.
Yeah.
So you can see there's a defect in the patella.
Yeah.
And when you see inside the joint,
it's a big
that
piece.
was a big piece. So
yeah,
this was a very big piece, more than 2.5 centimeters by 2 centimeters, quite thick. And he also had a good amount of cancellous bone on the undersurface, and luckily it was not fragmented.
Yes.
So this is what I got on table.
Was there any subluxation
of patella?
Must be.
Yeah, this was a dislocation patella case.
No. During the arthroscopic view, was it subluxated?
No.
Something
It was quite reduced. Yeah, it was. There was a lateral laxity, but it was not dislocating. It was subluxated mildly, but very easily reducible. It was an acute case. Okay. Now, I'll tell you, the patient himself is an orthopedic surgeon, so the game changes. We are doing at the very early stage. So immediately on table, we decided that, okay, this fragment I'm going to fix. And I discussed with him that, okay, we will try fixation, because that time, again, we did not have many cases of fixation of patella at his age. And I was not sure whether this works or not. So mini arthrotomy was done in the same sitting. This I could fix the fragment nicely, and as Drumil had said that the headless screws don't hold much, but luckily I was able to put 1 or 2 screws here and fixed with a lot of Vicryl on the edges, and got a very good. Unlucky, I don't have the pictures here, but we got an almost 90% coverage of the defect. Now, what happens whenever you remove a piece of cartilage, such a cartilage from the joint, it doesn't fit the crater. It opens up. So we need to do a little trimming, little pressure, and only then we can fix this fragment back. But that was done, and MPFL was reconstructed on table. Again, my mentality was to repair, but after discussion, it was decided that we should reconstruct. We should not take any chance for the repair. And with the SEMIT, this with a double fixation on the patella and single tunnel on the tibia, femur. On the femur, this was done. The reconstruction was done. And 5 years down the line, this gentleman still heavy, but able to do this. So this has actually enforced my belief that cartilage does heal very well, though it looks very bad, and the age is not a criteria. Um, I don't have the pictures, but and repeat MRI was done after 2.5 years, and the cartilage was sitting very nicely there, and symptomatic function is doing very well. So he has a stable knee and a good cartilage on the middle facet now. So this was a way of thinking about patella. But now let us decide. Let us discuss what can happen wrong with the patellar cartilage. So when you're talking about injury, it can be a direct trauma, it can be a patellar dislocation, or it can be a maltracking. So direct trauma can happen to the patella with a dashboard kind of injury or a fall on the flex knee. This is a typical central injury on the patella or the patellar cartilage or on the inferior pole. There is a second entity called the patellar dislocation, which we saw just now, when the patella jumps out laterally, and that time it rubs on the lateral femoral condyle. So it causes injury on the middle facet of the patella. Very typically, either it gets abraded or the whole cartilage may come off, which was seen in this case. There is also in the MRI, the bone marrow edema seen on the lateral femoral condyle edges, which is typical of a dislocation of the patella.
That's the
Sorry.
Yeah, that is the hill sacks of the knee.
Yeah, exactly. So perfect. I'll remember the analogy.
Yeah.
And the third thing is the maltracking, which can happen because of the malalignment, the rotational malalignment, or the valgus of the knee, or problem with the foot or the hips. So a lot of things can cause maltracking of the knee. So now my question is, what pattern of patients do they come to your OPD? The direct trauma, patellar dislocation, maltracking, which is the maximum number of cases coming from?
Usually the patellar dislocations with this type of what you presented. This very typical of the dislocation with the medial side lesions, either on the odd facets or the superior medial facet, which is because of that pull off and this MPFL. So usually in this area, what you showed was a great technique, and probably everything healed well. But otherwise, this part of the patella is a quite forgiving part. If so, even if it was sacrificed, a smaller piece, this would have still done well as far as your joint is stable, your patellofemoral joint is stable.
Okay, so I'll give my thinking over this, why I did the fixation. If you see the MRI, we'll show the MRI once more. That cartilage defect is very big. It's taking off almost the whole middle facet and also going up to the median ridge.
So this was a right case for what you did. But most of the patients which I have encountered are much smaller defects.
I agree.
So I already disclosed my agreement with you doing the same type of procedure, so don't disagree. But I also agree with Nilesh Bhai's view that many a times I see this type of patellar maltracking or chronic dislocation in which I do arthroscopic evaluation also before doing MPFL reconstruction. And what I can see is there is some older chondral lesion on the medial sided facet, which there is a sort of a very good fibrocartilage form without doing anything. And that fibrocartilage is exactly what has been seen in most of the chondral books post result, that this should be like this. So it's forgiving also. But I would have done the same procedure probably in acute case scenario.
So the difference here, Kunal, is the whatever you see in the MPFL cases. This is not because of the pressure. It is because of the lateral subluxation. So this cartilage injury is happening because whenever the patella is dislocating or subluxing laterally, it is shearing on the lateral femoral condyle. But it is not a pressure injury. The third group shown here is the maltracking. This is where the pressure is coming on the lateral femoral condyle. That's why I said, if the patient has a direct trauma, you have a central injury. If it's a patellar dislocation, it's a medial facet injury. And if it's a maltracking, it's the lateral facet injury. Because maltracking means the extra pressure is going on the lateral facet.
It is LPS, lateral hyperpressure.
Exactly. So that's the reason we are treating all these entities in a different way. But what I differ with Nilesh Bhai is that we have a very big number of patients coming to us as undiagnosed anterior knee pain.
Yeah.
And a lot of this, they fall into the third group of
Third
maltraction.
category.
Yes.
Yes.
So every time we diagnose them as CMP or chondromalacia patella, but actually this is the PFPS syndrome or the patellofemoral stress
Exactly.
syndrome.
It is hyperpressure and lateral hyperpressure.
And what we are missing, because we don't give enough examination time for the femoral torsions, for the gait, for their foot, for the hallux valgus, for their hip strength, we are not seeing and examining all these things, and that's the reason we are not able to pick up and treat that third group, which is a very important group.
And
And
we must look, what you are saying is a very right thing, and most of 80-90% of the patients are in this group.
exactly, and that's the
So
reason.
the Henry and David Dijon is probably has published Max in regarding this case scenario, or chondromal, we call it chondromalacia or PFPS. I think in his first two chapters, what he has mentioned is that this is a different nomenclature, but they all fall into the same category of anterior knee pain. And previous to visit to him, I used to give them rest and breast and whatever. But what is the treatment now? That they the Leo group suggests is a very aggressive quadriceps and hamstring strengthening protocols, doing squats, lunges, leg presses in the gym, and I have seen in my experience that these females of middle aged or whatever, they actually recover well.
So
But you are, again, you have to basically identify what Manoj is saying. Whether it's a dynamic maltracking, there are the issues with the soft tissue, the muscles, the tightnesses, the bony malalignment. All this, once you figure that out, then only your rehab is going to work.
perfect. So Nilesh Bhai is saying exactly that the customized rehab is important.
You have to
And
tailor make.
yes, and so what happens, for example, patient has a foot problem, you might need a foot orthosis to correct the flat foot, and that
Yeah.
would correct your knee problem. If the patient has a hip problem, you stick to the physiotherapy for the gluteal strengthening to improve the external rotator strength of the hip. If you have problem with the patellar VMO weakness, then you go for a VMO strengthening. Sometimes the VO may be strong, but the VMO and the VL are not firing in tandem. Then you need to correct the biomechanics of the VMO VL firing. So
Yes.
that is important. Okay.
I agree.
And again, here we have to assess the hamstrings,
Hamstring.
because hamstrings overload, IT band, IT overload, these are the very important thing which increase the PF pressure. So if you do not release those things and continue to do only strengthening, it may be counterproductive many
Yes. So
times.
sometimes you find the patients worsening after your physiotherapy because we are not taken into account about the tight structures like the ITB or the lateral retinaculum
Yeah.
or the even the gastrosoleus tightness.
Yeah.
So this can also hamper with the knee function. Yes, and the flexion deformities.
Yes.
Okay. So that is the reason. So one very important way of treating the chondral injury in simple way is just observation and physiotherapy in a proper way, and sometimes orthosis, rather than
And
doing
basic,
some complex surgery.
yeah, we have to involve ourselves
Yes.
in all these patients.
So now,
Yeah.
understanding this spectrum, we have either physiotherapy and orthosis, a cartilage restoration procedure, which we discussed in the future in the pre-lectures, and the bony correction or surgery. So suppose if somebody wants to go for, like, if you've done a physiotherapy, cartilage restoration if required, and what we can do for the surgical correction of the for the pain. So we have options like trochleoplasty, which Dr. Prasad is going to talk about. We have an AMZ procedure or an embryo procedure for the tibial tubercle, or a tubercle osteotomy for the patellar realignment, or a distal femoral osteotomy, or a proximal femoral osteotomy for the torsions, or we have PCL reconstruction. We should never forget for the anterior knee pain. So lots of procedure can be incorporated for preventing the cartilage loss or just adding to the cartilage repair.
But only PCL reconstruction when you have a PCL deficient knee.
Yes, only. I'm talking as a spectrum because we have very limited time, Nilesh Bhai.
I know, I know.
Just want to finish the list. Sorry.
Yes, yes.
Yeah, and we should understand the location of the lesion, very important, and then decide upon the type of procedure we need to work upon. And very important is this message of the median reach, because Niemeyer had described something like a double eye technique. So when you're doing a big lesion in the patella, and if you are not looking at looking at preserving the median reach, what will happen? This is going to fail, because that's the area which takes maximum load in stabilization of the patella.
True.
So after all these options, we need to decide what is simple and best for us. So for me, it is the physiotherapy, bracing, try to repair when the anatomy as well as early as possible, get the physiology back, and only then we develop upon the complex procedures for the cartilage and the bone. Dr. George Muzopoulos had tried to, with this Siebold, they had a paper, very complex algorithm for the different pain. But if you see all the papers after this, with this complex procedures, the results are not really good. The reason is because very ill understanding about the biomechanics of the patellofemoral joint. One question always arises in mind, suppose if I'm going to realign my patella in the instability, can I prevent the loss? So for that, you need to understand the type of dysplasia, which kind of continued procedure you are going to do, and the choice of restoration. Because if you make a mistake here, these surgeries are not going to work. And now with the fresh input of the papers, it was 17. This paper very successfully says that they could send all the patients with the autologous this osteochondral transplantation back to sports in 6 months. So this is that light at the end of the tunnel. So probably with our better understanding of this biomechanics and this surgeries, probably we are looking at much better results.
Call mom. I'm on a
Okay.
webinar. Nice, excellent. Any other questions to Manoj? I think for the paucity of time, we move on to the, I think, last presentation from Pratnesh.
Yes, sir.
Okay. Thank you, Manoj. Excellent discussion and excellent talk. Yes, Pratnesh.
So can you see the slides?
Yes, yes.
So we'll just be talking about arthroscopic trochleoplasty. I'll just give a brief overview regarding patella instability. So patella instability is basically affected by predominantly bony factors, which are trochlear dysplasia, which can be seen in up to 96% of the patient, abnormal patella height, and pathological TTTG distance in this order of frequency, and patella tilt can also be an associated factor. There can be secondary factors like varus valgus, genu recurvatum, torsion, patellar dysplasia, and abnormal subtalar pronation. Now there is a DiGeorge classification which classifies the trochlear dysplasia into 4 types. Type A being most mild, to type B, type C, and then type D. The type normal trochlea is a sort of a can be either a shallow or a flat or a convex trochlea. It can have a double control sign. So as we see, type A, type B, type C, and type D. Type B and type D have a supratrochlear kind of a spur, and you have a crossing sign in type A, B, C, and D. So crossing sign can be seen in up to 96% of the patients. A shallow trochlear depth is seen in up to 85% of patients, and it is pathologically if the trochlear depth is less than 4 millimeters. There can be a trochlear bump which is seen in up to 66% of patients, and it is pathologic and it is significant if it is more than 3 millimeters. This does not mean that we need to do a trochleoplasty if it is more than 3 millimeters. I'll come to the indications of trochleoplasty later on. And then you can have a double contour sign and trochlear bead. Now this is a Lorentz view. Lorentz view is basically axial at 20 degrees, which can actually give you an idea about the patellar tilt. And then you can calculate the lateral patellofemoral angle. Now this is a small algorithm that we usually follow. If the patient has a minimal bony changes, that is the type A or C trochlea with less than 20 mm of TTTG distance and less than 1.2 millimeters of catenchisms, that is, there is no patella alta, then you can just do a soft tissue procedure like MPFL reconstruction and go away with that. But if you have a TTTG distance which is more than 20 millimeters, ideally a tibial tubercle osteotomy should be added. If there is a type B and type D trochlea, that is you have a supratrochlear spur, and specifically if you have a supratrochlear spur which is more than 5 millimeters, then a sulcus deepening trochleoplasty is warranted. And if you do a trochleoplasty in these patients, you can do it up to TTTG of 24 millimeters, because when you do a trochleoplasty, the TTTG distance will actually decrease. So if it is a very severe trochlear dysplasia with a TTDG more than 24 millimeters, which is a very, very rare occurrence, then you may need to do a trochleoplasty along with a tibial tubercle osteotomy. And if you have a significant patella alta, you may have to add a distalization. Now we'll come to indications of trochleoplasty. Trochleoplasty is an advanced surgery with the limited indications as of now. The major indication is you should have a prominence, the supratrochlear spur should be more than 5 millimeters. This is the important indications as per different studies. You can do it in advanced dysplasias like dysplasias B, C, and D. The apprehension should not only be in extension but also in flexion. So you should have an apprehension in a flexion of about 0 to 50 degrees. The trochlear inclination should be less than 11 degrees, and you should not have cartilage changes. You should not have condyle changes on the trochlea, so that the condyle changes on the trochlea should be less than ICRS grade 2. Now, if we talk about the trochleoplasty, the trochleoplasty started with LB's elevation trochleoplasty. This was the first. This was an elevation trochleoplasty, and then there was deepening trochleoplasty, which was described, and then there was a recession trochleoplasty, which was recession wedge trochleoplasty, which was described, which actually remove a portion of the wedge of the bone while doing it. And then Dichot described what is called as a sulcus deepening trochleoplasty, in which he removed a triangular piece of the bone at the trochlear sulcus and then just pushed the cartilage down. This is an example of the open sulcus deepening chondroplasty. So open trochleoplasty is quite a successful procedure in these limited indications that I have told. So this is how it looks, and usually we put one or two central suture anchors, and then we'll use a vicryl sutures to use a knotless 1, 2, and 3 sutures to actually compress the patellar condyle flaps. So it's a very, very successful procedure, but it has a very common complication of post-op arthrofibrosis. So in different surgeries, the post-op arthrofibrosis can be seen in about 2 to 42% of these patients. And this is a very good prospective study which shows that a manipulation under anesthesia is usually not adequate procedure in those patients with arthrofibrosis following a sulcus deepening or tracheoplasty. And most of these patients, in his series, it was about 25% of the patients needed a post-operative, second stage arthroscopic arthrolysis for attaining of good range of motion. So post-op arthrofibrosis is a concern in this open trochleoplasty group. So to prevent these problems of arthrofibrosis, there is a technique which is an arthroscopic trochleoplasty. I'll just present the case. So she was a young 32-year-old lady, and she had an episodes of patella dislocation, and she had a trochlear dysplasia. The patella was dislocated both in extension and also in flexion. So even in flexion, the patella was dislocated laterally. So it was a significant trochlear dysplasia, almost convex type D, and it was associated with a significant patellar tilt and dislocation of the patella also in the flexion, so around up to 70 to 80 degrees. Now when she is walking, you can see that the patella is tilting on the left side. You can see the patella is subluxating when she is walking, and she has a significant apprehension in walking. This was her x-rays. There was a significant supratrochlear spur. The patella was hypoplastic. The dimensions of patella was really less. The Caton-Deschamps ratio was slightly high. It was 1.32. It was not very significant, slightly high. And this is a MRI pictures. And now the recent studies shows that trochlear dysplasia should be graded according to the MRI. So if we see here, we can see that there is a significant convex trochlea. There is trochlear damage, chondral damage on the patella, but not that much chondral damage on the trochlea itself. The spur is prominent. You can see that there is a significant facet asymmetry. The trochlea is not very well much visible, and there is a significant decrease in lateral trochlear inclination. Now what we use, the ideal fixation, which is historically described, are staples and headless screws, but now we are using knotless anchors with vicryl sutures. Normally we recommend a push lock anchor. We use normally one anchor in the center and use 2 to 3 peripheral anchor in a knotless pattern. So this is the initial, we do it in a supine position, and this is the initial pictures that we saw. We do a removal of the supratrochlear bump or supratrochlear spur from the superolateral portal, and we just then put the grafts. Now the whole procedure is to shift the trochlear groove laterally and to decrease the TTTG distance along with the deepening of the groove. So this is the pre and the post-op pictures. If you see, this is the pre and post-op pictures. Now this is a small video clip in which I'll just show you how we will elevate the flap. This is a tedious procedure. So now we are looking at the from the superomedial portal, and here we can see that this is the medial patellofemoral ligament, which is very weak here. Now we'll insert the passport cannula and we'll release or remove the synovium from the top of the trochlea. So we'll remove the synovium from the top of the trochlea in a nice way, because this is the area where there is an extra bone. And so when you see here at present, you cannot see any formal trochlea at present. So this is almost like a convex kind of a trochlea. And then we have, this is the patella. If you see upwards, that is the patella, and there is you can see some trochlea, some cartilage damage or the fissuring type 2 kind of a damage on the patella side, if you see here. And then at this point of the time, we will mark up our, now we use 2 burrs. Here we are using the smaller burr to just mark the level of the resection initially. So we'll just mark the level of the resection initially like this, and we'll go from lateral to the medial aspect of the patella. So the trochlear groove is prepared. We'll remove a lot of bone in the center because we want to just do a more and more resection on the undersurface. So this is a 2.5 millimeter burr, and this burr is used just to create the level of the resection. And once we are able to create a good level of the resection, we know that from where to where we have to do the resection, and then we will switch on to a larger burr, and we'll go and we'll keep on elevating the flap as such, and we'll gradually deepen it to the level of the trochlea. So we'll go from the lateral side and go up to the medial side. This is a tedious procedure, and this takes time. You have to be patient in doing this procedure. You should not hurry because we don't want to fracture the flap. So we'll go very slowly in this particular area. So we'll resect it, and we should be sure that the flap that we made, and then we can use a small chisel or osteotome to make the final elevation of the flap. So the final medial aspect of the flap can be elevated with an osteotome, and then we will resect the center more on the center. So then we'll resect more tissue on the medial aspect. So we'll just use our burr more and resect more bone on the trochlea. So we'll keep on resecting more bone. And now if you see that now there is a good trochlear trochlea that you can see. So previously you were not able to see that trochlear groove. And once we resect this flap, Then when we go up, you can see a good trochlear flap. So if you see from here, so when we release a good amount of bone, you'll be able to see a good trochlear flap. And then the rest of the procedure is simple. We just have to put the push lock anchors. So here, when what we see is, we can just see that there is a good trochlear groove which is formed if you elevate a good flap. And then you can just use one anchor here, and then use the, in a knotless fashion, 2 to 3 anchors to just compress it in a lateral pattern. Now, this procedure usually is not useful alone. So we combine it with an MPFL reconstruction. In this particular case, we use gracilis, and we did no we didn't use any holes on the patella, but the patella was hypoplastic. So we did a technique which called as a MQFL reconstruction. So we pass the gracilis tendon through the quadriceps tendon. And if you are doing any open procedure, you can do a lateral retinacular lengthening. In this particular case, we didn't do any lengthening. And this is actually the final appearance of the groove. Thank you. This is a procedure that I have done recently. So I didn't have a follow-up. I did this procedure just before the lockdown. And as per the telephonic conversation with the patient has having full range of motion and does not have any problems as of now. Thank you.
Thank you, Dr. Prathamesh. It was indeed a wonderful presentation, but very skillful surgery. So I'm not sure how much of the panel, the speakers would have experience regarding this, but definitely a wonderful procedure.
Question here, Dr. Prathamesh.
Yes, sir.
The last picture which you showed was showing a vicryl tape.
Yes, sir. This is not my picture, sir.
Okay, because it's not available, because that's what we are looking for.
We are using number 2 vicryl. We are using a number 2 vicryl for this particular procedure, sir.
Yeah.
We are using push lock suture anchors with number 2 vicryl.
And the question was because our main worry is to get that optimum level of bone below the cartilage. So what you had shown here was a very nice thin flap, and at the end very nicely closed. So do you think it's easy to do it without a zig, the one which is being marketed by Arthrex?
Yes, sir. I think zig is not that much useful. If you can elevate the flap nicely with a burr, the jig is not very much useful. You need to have a thin sliver of cartilage and the bone, which you can elevate from underneath the cartilage. So the jig is not very much useful, but definitely these unique knotless implants are definitely useful.
Yeah. So the main advantage of zig, what we find is that it will not allow breaking of the
bridge
control. So we are not going to injure the cartilage. We don't go too deep. So can we do it without zig that easily, without breaking the cartilage?
Yes, sir. Yes, sir. Yes. It takes some time. So that's why I'm telling you that you need to be patient in doing this step. The elevation of the flap is the most difficult step, and you should spend time and do it very meticulously.
Great. Very nice.
One question is, other than this particular case, in your previous experience, specifically for a non-athletic community, what is your experience of, you would have done isolated MPFL reconstruction in this type of cases? Are there any recurrences?
Yes, sir. My personal experience of MPFL reconstruction is the results are good. The results are not excellent. If specifically the patient has bony abnormalities like patella alta, trochlear dysplasia, or increased TTTG, so then the results are good. They are not excellent with a solitary MPFL reconstruction.
So by not being good, you mean recurrence or pain, or what exactly? How you evaluate your bad results?
Both. So the patients who are not happy, some of them do have a sort of a tightness in their knee. Some of them may have a crepitus, and occasionally 1 or 2 patients have also complained of a recurrent subluxation kind of a picture. So solitary MPFL reconstruction in cases which have a bony abnormalities, I am little bit reluctant in doing. So if the TTTG is more than 20, and if it is a significant trochlear dysplasia like type C or D with a convex kind of a trochlea, I am skeptical in doing a MPFL reconstruction alone.
So basically, it being an evidence-based medicine, I wholeheartedly support this thing that you need to first address the bony abnormalities, then only doing a soft tissue
Yes,
procedure like
yes.
MPFL. But if we talk about the practical experience specifically in our country without any sports involvement, somehow the results are not that bad as been documented in literature. But I do support the evidences. Yes, of course.
A lot
Yes,
of these
Manoj bhai.
cases with this trochlear dysplasia would have a elongate base, abnormal catenisms and a very long
Yes, sir.
patella alta. So
Yes,
do
sir.
you combine them along with this TTOs distillation?
I have not done so far, sir, but it can be, yes. Ideally, it can be. So as this algorithm goes, if you have a TTTG of more than 20 to 24, you can do both. You can do a tracheoplasty along with a TTTG, tibal to
No,
prosthetic
no.
transfer.
I'm talking about the distillation because
So you can combine it with the tracheoplasty, yes, sir. In some
because
cases, you can
if you
combine.
have a patella alta
I have
and
not done
you
it so
do
far.
a trochlear dysplasia surgery or tracheoplasty, then the problem is again the biomechanics are still not uh, restored in those cases. But then it would be a
Yes, sir.
very
So
big
if
surgery. Yeah.
I think
yes,
some
it
of the
makes.
distalization also been taken care by trocheoplasty itself, probably.
No, no, no.
Uh,
Distillation cannot be taken.
Distillation this trocheoplasty take care of the medial lateral part. It
Yes.
will not take care about the alta as
It
such.
will reduce the
So,
TTTG, but not reduce
ha,
the. So,
it will reduce little bit of TTTG. Yes, it
so
will
because
not
one of
reduce
the
alta.
so one of the technical difficulties in doing trocheoplasty is breaking that flap to get the
Yes, sir.
shape back,
Yes,
which is a very difficult thing actually. That's the reason Dijur
yes,
always cuts the this cartilage
yes,
in the center with a knife.
yes, yes.
So I think that was a wonderful discussion and a variety of bunches of cases. And with that, probably we can, with the permission of the panelist, Dr. Nilesh Bhai, can we end this session and thank our dignified faculties,
Yeah.
our faculty from Mohali, Dr. Manit Arora,
Yes.
Dr.
Thank you,
Manoj
sir.
Bhai, Dr. Dhrumil from Baroda, and Pratmesh from Ahmedabad, and of course Nilesh Bhai and Sanjay Bhai from Ahmedabad. So
Thanks a
thank
lot.
you all very much. Thank you very much.
Thank you. Thank you, sir.
Take
Thank you.
care. Bye bye.
Take care. Bye bye.